Good morning, everybody. Robin Strong in here, and I am really excited to be speaking to Dr. Chloe Bird today. I've been a big fan for a very long time, Chloe. You've been doing unbelievable work in the field of women's health, very broadly defined, and we're actually talking today. You're in Aspen. Is it the Ideas Festival?
Yes, it is. Both
Okay.
Ideas Health and the rest of the Ideas Festival.
Got it. Got it. I was there. My gosh, I was invited to moderate two pretty cool panels. It was so long ago. I think Dr. Oz was one of the, but he was still with Oprah. That's how long
Mhm,
ago. And I think
mhm.
Deepak Chopra, is that a name from the past? Was
Oh, yes.
there. So
I've seen Deepak here.
is he
Yeah.
still coming to the, oh my gosh.
Sometimes I spoke here in 2023, and
Oh,
I've been
right.
coming back
Oh,
ever since because
okay.
it's just an incredibly exciting kinds of conversations happen here.
Yeah, you walk away with so many new ideas and we still have a lot of the same challenges, but we have a refreshing energy that you leave. And I hate using that word, but in this case, I think it really, at least I always felt very energized when I left. So you are there. I did not know one has to adjust to the altitude situation. So that was a bit of astonishing shock for me. I learned a lot about that, but that's for a whole nother discussion. So we're going to bring it back to women's health here. And I do want to start by high level introductions, because of course we will have all of this on the Health Dame website. But by training, you're a sociologist, which really fascinates me. And I'm going to ask you about that in a minute. But you're a professor of medicine. You hold the Sarah Murray Jordan professorship at Tufts University School of Medicine, and you're program director of the Center for, let me get this right, Research on Women's Health, Sex Differences, and Population Health at Tufts Medical Center. I also want to mention that you've received many, many distinguished awards over the years, very well deserved, and we will have a list of those as well. What I'd really like to kick off with is, why sociology? How were you drawn to that in the beginning? And related to that, how does that inform the work you're doing today? That background.
Interested in sociology because you look at social problems, issues, complexities that face society from different levels. I was very aware that demographics can
Hmm.
play into the size of different cohorts, the economy at the time you come of age, or the environment you're living in shapes your life and your opportunity, and how different groups experience opportunity or lack thereof.
And when you were a student, was the whole idea of gender, sex differences as much of a focus generally for your work, or did that kind of evolve your area of interest and specialization over time?
I started out interested in sex differences and in economic opportunity. And I didn't want to spend what looked like at the time a career arguing over, did this amount of money matter? Or was it because women didn't try enough? It wasn't important enough for them. They didn't negotiate well. And when I got into graduate school, I was in a department very strong in medical sociology,
Okay.
and got interested in looking at their health consequences, psychosocial depression, just overall well-being and distress that are associated with the kinds of patterns of equity and inequality and opportunity. So I just started doing some of that kind of work, because you can't say women get sick more because health isn't as important to them.
Right. No, you certainly cannot.
And it was also immediately interesting to me that women live longer, but they get sick more. So there was a biological complexity going on there that's different than if you look at other socioeconomically disadvantaged groups get sick more and die younger. And so there was more that needed to be done. Another thing that came out when I was in graduate school was we didn't call it gaslighting, but a
Okay.
lot of anger with the medical community for not being prepared to diagnose women's heart attacks or other health problems. And in thinking about it, I felt like we can only have good policy if we do the science that understands a problem. We can only do good medicine if we understand women's health. And so from my side, it was on us to do the research so that we could so doctors would have an opportunity to provide the health care. And I've done all kinds of other work on health, but it keeps coming back to this problem of we haven't made that much progress on in the big picture of addressing all of the gaps in the science on women's health.
There are so many, it's hard to know where to start because, healthcare across the board is so complicated and complex, whether you're talking about the biology, whether you're talking about bias, whether you're talking about access, and that's just the tip of the iceberg.
Mhm.
I remember when I was in, I want to say it was middle school or high school, there was a riddle that was going around where there was a surgeon walked into the operating room after a
Mhm.
car crash and said, I can't possibly operate, this is my child. And no one could figure out the relationship because because the dad had died in the car crash. And so no one, is it adopted? Is it this? Is it, because no one could imagine that the mom would be the surgeon. And when you don't have women in those positions, that also changes the dynamic. Women physicians, women researchers, you ask different questions when, etc. Your current work, as I understand it, is focusing on the gaps in research and the evidence base to be able to improve health and healthcare. And I think before we dive in, I do think so that we set a level playing field. When you talk about sex differences, what does that mean in your vernacular for what you're studying?
Primarily, what I'm studying is male-female differences in
Okay.
health, healthcare, and outcomes. I'm certainly interested in a full biological continuum of people and their biology, but we haven't even done the basic of being able to understand many aspects of normal female development, much less incorporated understandings of what a disease is like in women into studies of how we intervene in them in, cardiovascular care and other areas.
Right. So even taking out all the reproductive stuff, which is impossible to take out, but there are all these other conditions. Women get, sick outside of what's known as bikini medicine and all of that. And so is it getting better today? Where are the gaps today? Would you say the biggest gaps that you are seeing?
That's hard because the
Yeah.
prevailing view is it must be getting better and it's just not happening fast enough for Chloe. And in fact, when we did the National Academies report that came out in 2024, we looked at NIH's funding, and what we found was 8.8% of the funding addressed the health of women, including reproductive health. Now, that's pretty horrible
Yeah.
given how far behind we already are. So there's nothing like catching up. We're actually falling farther and farther behind. Of that 8.8%, the largest amount went to breast cancer.
Okay.
More women die of lung cancer than of breast
Right.
cancer.
Right.
Cardiovascular disease is the leading cause of death in women, as it is in men. And the second category was HIV, because there's still increased funding around that, which is very important, but again, not getting at the big picture. And then I believe it was ovarian cancer. So when you think of the entire pool of disease burden women experience, we've got tiny amounts, and it's not even distributed very evenly across all of the kinds of issues.
What are the barriers that you're seeing that, I mean, some of them are easier and lower hanging fruit, and a lot of this has been discussed, but what are you seeing that are some of the barriers?
So part of it is that there is a NIH and funders tend to have a certain kind of conservative-ish approach to building the science. You want to make a certain size step. So it's likely you get a valuable answer, but not entirely invented newly. So it favors building on existing evidence base over things that are entirely exploratory, but it doesn't value a replication. That's very important in science, but not been very important to funders. Women's health, anything that focuses on the health of women, and I'm mainly talking up through 2023. We've got a whole other set of issues going with cuts in funding that haven't made any of this better. But I'm not talking about a new problem. But research gets discounted for looking at something that we already think we understand in men. So it gets discounted on the score of significance because male bodies still get treated as normal bodies and women's bodies get treated as atypical, which you see in normal female presentation being called atypical across many diseases, including cardiovascular disease, where we understand it's not atypical. But we don't score as highly for those grants where they are looking at something in women than when it's looking at men. And they don't score as high on innovation when it's doing something that's been done. And part of the innovation score has been around using cutting edge technology, which is not necessarily what's most important when you're looking newly at something, but in a population you haven't studied before.
So the funding you're referring to is largely government funding, academic research, not so much private equity, private funders, venture, or is it? Is
Well,
that separate?
we focused on NIH funding in many studies because you can see the entire pool. You know what the
Okay,
denominator is. You know what was happening. The scoring process, the rubric is out there. We can look at what's gone on. It gets a lot more complicated to understand what ideas got put forward in other spaces. But the private equity world relies on the basic
sure.
science building that happened in NIH, and there although we've demonstrated incredibly high returns on investment on funding research on women, the impact on science, the return on investment, and the impact on population health
Right.
is tremendous. Boy, the risk perceived by funders is often somewhat higher in some areas because we have less information on the biology, because it's not connecting to as developed an evidence base. So we need to get the funding so we de-risk science on women.
I think related to that is enrolling women in clinical trials and research studies. And that's still woefully low for the reason that you described as the male is the default subject, the male body, etc. There's a history of why, and that's been written about a great deal, starting in the 50s with healthy middle-aged white men being the standard, the what they call the gold standard of clinical trials. I say we go for platinum standard and kind of include more than that. And that really hasn't taken off the way we'd hoped. And I think one really excellent example of that crystallized for me this whole issue. Kevin MD is a podcast that I like to listen to, and he interviewed a surgeon, a specialist in hernias. And
Mhm,
there have been maybe 6 major clinical trial studies on hernias.
mhm,
7 women were enrolled in the entirety of those 6. And so
mhm,
the evidence base is absent women. And so what happens is that feeds into the dismissal cascade that women find. You present with pelvic pain and you immediately get sent to a gynecologist.
mhm,
You immediately get diagnosed with ovarian this or endometriosis that, and according to this interview, it
mhm,
takes women 2 years longer than men to be diagnosed with a hernia
mhm,
because of this, and the outcomes are much poorer, the rates of death are much higher. And it isn't because there's necessarily a clinical bias among the individual. It's just if the surgeon were to look in the literature is lacking because at the very beginning, there are not enough women in the trials that then roll into the evidence that rolls into the literature that the surgeons are looking at to make their diagnosis. So this is how it starts and ends poorly. And now I think you've been doing some work with AI of how all of this evidence base, again, is a gap. And so what do we do about informing AI correctly? What's going on there?
Well, let me back up to the women not being included because there are really two problems here.
Okay.
We're looking right now at cardiovascular disease, and one problem is, did you enroll enough women? Were women enrolled at least in the proportion in which they're in the population with the disease, so it matches their age prevalence? And that increased because it was forced. It didn't hit that actually hit the level, but it increased with the NIH Revitalization Act in 1993 when Congress stepped in and said you have to include women. And that was a massive fight
Right.
that I'm going to be writing about. We actually want to end up writing a book on some of these problems and issues, myself and Gabby Alvarado.
Wow.
Uh,
Okay.
she's one of my former MD, PhD grad students from RAND. But now I'm working with Hamad Ali Ibrahim, another one of my MD, PhD former students from RAND, on what the gaps are in cardiovascular disease. quantify what's missing. And one part is, did they enroll enough women? That part could be addressed if NIH and pharma required study sites to enroll enough women. You don't get paid if you don't enroll enough women. We would figure out how to get that problem addressed. We'd figure out what the pain points are, if it's different with different age groups or different parts of the country or different populations of women. A lot of reasons you can imagine, because
Yep.
women do so much more caregiving, maybe more impoverished and more impacted by the costs of participation, which often aren't well reimbursed. But the other part that we're seeing is failure to look at what does the disease look like, or what feeds into it among women.
Yeah.
And so, did our female conditions or expressions even included? Or are we looking at a disease the way it presents primarily in men? And that's what happened in these hernia studies, of not even starting from the premise that there's a way it looks in women and there's a way it looks in men. Men and women also have some different hernias. Women
Right.
develop some out of childbirth, pregnancy, that matter. We haven't even paid attention to how you address that very well over time.
What would be the motivation, other than it's the right thing to do, for researchers and funders? Is it that they're worried about the legal implications, which way back they were with pregnancy? Is that still a fear? Because all of these things can be addressed. And I also sometimes think maybe we just directly educate women that they should be demanding to be in clinical trials. And, like maybe a lot of women don't even know that there are these opportunities that not being afforded for them in general, because we all know people who have different conditions. We care about, when you and your loved ones are impacted by a particular disease, or you're suddenly more interested in that research. So how do we harness that interest among women to help them advocate to push this forward?
Patient advocacy groups work around that and are becoming an increasingly critical
Good.
part of the entire equation. And that's something that the Chan Zuckerberg group has focused on in BioHub and rare
Mhm.
as one diseases. So that may be one important avenue for women to learn about their health, learn about options. But you need to know about it both in terms of disease intervention and other aspects of normal health or prevention. And I don't think the most efficient approach is going to be trying to educate all of the women to go
Okay.
looking for clinical trials. I think we need to change what's expected. I would like to change it by changing what the norms are. I would
Mhm.
like to start grading clinical trials and not be at the mercy of whether the journals use they're called SAGER criteria of the standards for looking at sex and gender, but simply to look at whether or not they're including enough women, whether or not they have looked at sex as a biological variable, either, as I was mentioning before, looking at conditions that are relevant to women, or pre-planning and testing whether or not the findings appear to hold for women. Whereas the proportion of women included increased, and after there was NIH put in place a policy to look at sex as a biological variable, but it's a checkbox. It isn't forced. You
Oh,
have to assert a plan. That increased considerably, but it's in the low 20s, I believe, percentile. That pre-plan and do that work, but they're because they're so underpowered, the so underrepresented in terms of women, there's still a problem. I would like to start looking at how are we doing? Because if we don't have a measure, you can't tell if there's progress.
who would do the grading?
Actually, Hamed and I may start doing it ourselves. I mean,
Oh my
I've been
God.
moved by our friends at Leapfrog and how much power there is in saying this is what in fact it looks like. And we've tried for years to get others to take on that responsibility and make it a priority, and it hasn't happened. So now I'm looking at, maybe we can just do this independently and put up a set of measures. And I'll,
I love that
collaborate with a
idea.
funding source that's interested, a group that's interested in supporting it. And I've been talking to people about that here. So,
Interesting, interesting. At Aspen.
yes, at the
Yeah, and how
Ideas
is it being
Festival.
received? Are you having people push back? Are people intrigued,
A
excited?
lot of enthusiasm, a lot of
Okay.
people asking, are you speaking this year? Are you talking more on that? But definitely a lot of enthusiasm for what's possible in addressing these persistent pernicious gaps that so here's the irony. If we want to understand human health, and everybody benefits from understanding
Of
human health,
course.
not just because everybody's related to a woman,
Right.
but we will understand men's health a lot better. Men are not a monolithic group. There are many things that we can understand that come out of in studying infectious disease in women, immunology, patterns of inflammatory response, and so on. We'll get better science and healthcare for everybody. So it's really a win-win at a societal level. For motivating investment for devices and pharma, it's a matter of making it clear there's a market for different kinds of interventions.
And I will do a shout out because Health Dame was one of the original members of the Global Women's Health Network, and they
Mhm.
just opened applications for their Elevate Investment Initiative, which is really engaging and encouraging investors to
Mhm.
accelerate capital flow in women's health. And there's a whole program, and it just open this application process, and there are really renowned experts working on this and very serious about addressing the issues you're talking about in the areas of cancer and cardiovascular and some very specific women's conditions, endometriosis and others that have been overlooked and sort of forlorn for way too long. So there is obviously, we're hearing about it all over the place, very important work in menopause and other areas that have been stepchildren of other conditions. And I think those are really important. But I think until we really raise the bar on the systemic big problems that you have been studying
Mhm.
all along the way, and your most recent piece, say a little bit about the Science Advances commentary on the precision medicine, because I think that one's just garnering a whole lot of attention, and I think
It
it's
is.
here. Its time is here.
It is exciting and encouraging to
Yeah.
see the number of downloads. I think it's approaching 2,000 already, and it's only been out a couple of weeks. And we're just looking at what is the nature of the gaps and what is possible and documenting those patterns. So it's a, fairly short, fairly accessible piece talking about what we need to do to address these. And I want to give a shout out to one other piece. The Science Advances was with Hamed, who I mentioned earlier.
Yep.
But Gabby and I just had a piece in MsMagazine
Oh,
.com, and that's on what the renaming of PCOS, polycystic ovarian
yep.
syndrome, to PMOS tells us about what's missing in women's health. It's a condition that affects 1 in 8 women, and it's gotten treated as if it's a small ovary problem, reproductive health issue, when in fact it's an endocrine metabolic condition, and the ovarian problems are part of, what calls it out, what is emblematic of it, but it is very serious and problematic. And that, along with other gynecologic multisystem diseases, take years and years to diagnose in women. The entire healthcare system, because we set it up around internal medicine with reproductive health off to the side as if it's plug and play, which is how it was thought of in the 60s, doesn't have the same configuration around specialists because we haven't done the research around diseases that cause so much disease burden in women. We don't have the same evidence base. Many of these things take very long time for women to diagnose for women at great expense, while their condition is worsening with
Absolutely.
potentially long-term disability issues as a result. So there's a potential to save money in doing it, not only save their health and well-being, save money for healthcare costs overall, but for healthcare to operate a lot more efficiently and effectively if there were a right place to go. Unfortunately, at NIH, there isn't a right place to go for endometriosis. We have, so we
Crazy.
need these things that cut across systems. That's an opportunity to learn so much
Oh,
more.
it's an enormous opportunity. And those are the kinds of systemic roll it up so that we can look. I mean, that's part of, I do a lot of programs on Health Dame with mental and behavioral health. And
Mhm.
it's not unlike where it's off to the side, but it really
Yes.
isn't off to the side. You can't
Mhm.
be healthy if you don't include the entirety of
Mhm.
all of these. And I understand it's very hard to do the research that's all things to all people just because we know so much about precision medicine and the individuality. And there are these systems, FDA and ethical considerations and IRBs, what is that? Institutional review boards and the
Mhm.
ethics of research. But we can't keep doing it the way we've been doing it because it's not getting the needle where it needs to be. So we
It's
have to be
clearly inadequate.
open. I really love your idea about this grading system because it enables a way for consumers, patients, individuals to have a shot at understanding what's going on, and it helps them become informed about, because ultimately we have to encourage one another to be part of research or we're not going to benefit from it. And I get that it's not going to be the general education of the average person, rah rah rah, but a little bit of knowledge goes a very long way. And I really think it's such a simplistic but and doable solution. Like, you can come up with simplistic, maybe not fair, but it's
Go with eloquent.
eloquent, it's doable, it's
Mhm.
scalable, it's practical. It will be hard to get to the agreed upon scale,
It's
but
verifiable. It becomes transparent.
yeah, yeah, yeah.
So basically, and maybe I should have led with this. What I'm interested in, having been at this on and off, pulled back again and again over the decades of my career, is why are we stuck? Why
Mhm.
aren't we getting farther? We have this
Exactly.
fantastic National Academy of Science, Engineering, and Medicine report on women's health and what it would take to start to address it. Actually, just to be making progress instead of falling farther behind. And these systematic reviews end up showing up as if they're qualitative. And what I get asked at the end of it is, well, what's your top three things? We're not going to do everything. And, when you're scraping the bottom of the barrel, the top three things is not going to fix it.
Right.
So what I've started to look at with Hamed and with Gabby is, how do we take this invisible problem that keeps flying below the radar and make it visible, unforgettable, and actionable? And so we look at different ways where we can take and quantify using the tools we normally use to evaluate the evidence base. But instead of using it to say, here's the evidence, this is what the guideline ought to be, or here's what we know is the effect of statins, say, who do we know it for?
Yeah, exactly.
Say what's happening there, and so we can look at the evidence on men's health, and then we can graph that across the quality of the evidence, a range of conditions or a range of ages. And then once you have that map and you go, okay, this isn't perfect, but this has got some reliability, then look at how much of that do we know for women
Mm.
and plot that and see if you can plot that on the same graph without a squiggly line on the edge, because there's so much less
Yeah.
that has actually been documented is the right answer in women. Of that, did it actually look at, are there differences in presentation? Are there differences in response to treatment? Are there differences in the conditions that contribute? And we're interested in looking at those along with diseases where the age prevalence
Sure.
is similar,
Sure.
but it's worse in men. Take chronic kidney disease. It's somewhat more prevalent in women, but men are more likely to have severe disease burden and mortality. And it's the exception that proves the rule. We need to understand what's going on in men. We need to look at that. So we're looking at how we can take these different areas and graphically display
Hmm.
what's missing. And the idea of measuring clinical trial by clinical trial or article by article for the clinical trials, how did they do in terms of assessing women's health, came out of that same goal of,
Yeah.
let's make it visual. Because what happens when I talk about this to many audiences is they hear, okay, there's a fence, it has some holes, they're not getting filled fast enough for Chloe. And really, we've got some fence posts, we've got some sections. We have nothing like an entire fence. And it's not that we're filling them and catching up at a glacial pace. We're falling farther and farther behind.
And
And we're
that's
leaving good information on the table.
There's so much information right now, and there's a willingness among people to be part of it. And it's just sinful to not be harnessing all of this I mean, it's life-saving information. That's the bottom line that we're leaving behind, and so it's really quite tragic, actually. And for those who care about markets, it's a missed opportunity as far as that goes, too. I mean, it isn't just, "Oh, we should be doing this because it's a good thing
Mhm.
to do." Again, I mean, there's markets out there that are not being tapped, and that's a shame, too.
Completely. I mean, the reason we see a high return on investment, and I was at Rand, co-directed the WAM reports on Women's Health Access Matters,
Yep.
and Ahmed worked on those with us as well. The reason we see this fantastic return on investment for cardiovascular disease, coronary artery disease specifically, we looked at how much funding had gone to that, how much of it had looked at women, and it was tiny. I think it was about 11%. I don't remember exactly. And so, what if we doubled that amount of funding for a year and assumed that could make 1/100% 0.01%
Oh
improvement
my gosh.
in the age prevalence, in disease progression, and in health related quality of life.
Okay.
How would that play out as a societal return on
Right?
investment? And we found a 9,500% improvement. So 95x. Rand didn't want us to talk about it that way because we weren't talking about a capital market, but that's really what we're looking at.
Oh,
And it was even higher for rheumatoid arthritis. It was in the same ballpark also for lung cancer. Even for Alzheimer's and related dementias,
oh,
it
yeah.
was over 200%.
Oh, god, yeah.
Now, you don't save as much money in those because you live longer if you and so things continue. And you have if you keep people from regressing, they're at home longer. And we valued the time of the caregivers as something that is a cost of improving.
I will say some of the dementias, as you know, are much more aggressive and don't
Yes.
last nearly as long, so they're not
Yes,
all the same. And that's a
absolutely.
yeah, so it's
That's a whole nother.
that's a whole nother issue. That's a whole nother issue. And I know we're way over time. I will mention one other thing that still is my pet peeve on, well, all of this is my pet peeve. In addition, the whole way that data are collected and coded,
Mhm,
because the whole time when my husband was approaching hospice, his primary diagnosis was Lewy body dementia with
mhm,
Parkinson's.
mhm,
But because it was easier for people to understand Parkinson's, it was easier for Medicare's paperwork with Parkinson's. It was easier. I kept screaming that that was wrong, change it, change it, change it. And yet it was Parkinson's as the primary. Then I get his death certificate. It was Parkinson's. Well, who's going to be interested in a market where the numbers are lower because
mhm.
the data are not capturing accurately? So within just my shout out for whoever's doing research out there and data collection, these things, they really matter, because I would love to see research. And again, sex differences in the
Mhm.
dementias is, something near and dear to me. And they're also different. And so I think you've like unleashed you and your teams and colleagues. It's exciting because these have been a long standing challenges, but you've identified fixable solutions that could happen if we just set our mind to it and get some oomph behind it. And I know we didn't get into any of the challenges in today's political environment, and that's really not what I want to focus on, because despite all of the challenges, you and your colleagues and others who I talk to roll up their sleeves and keep doing the work. And it needs to be done, and we just can't be stopped. So I say keep fighting that good fight while you're out there in Aspen. I'm really interested to hear what people think about this grading system. While
Mhm.
you're out there, we should follow up when you come back. I'm particularly interested in that. And for people who haven't listened to the Leapfrog interview I just finished with
Yes.
Leah Binder and what's going on there, it is really important for consumers to be aware that patient safety, research, all of these things matter in the end, because without this kind of information, the healthcare you assume you're walking into, fill in the blank, hospital, clinic, physician office, whatever, it is life and death, and we can
Mhm.
make it better. And we can't stop. So with that, Chloe, my final question, I need your song for the Health Dream playlist. Which song best represents this monumental effort you're undertaking here? That's a tough one, I know. And you could follow up with me. You don't have to share it this.
I think I'm gonna have to follow up with you, I
Fair
think, on this
enough.
because
Fair enough. It's a
but
big
it's
question.
definitely about hope and
Okay.
opportunity because I am increasingly convinced it's easier now to do the things I've been proposing for the past 5 years
Uh,
to map the evidence
I
and to
don't
say what's
disagree.
possible.
I don't
So
disagree.
it
It's
this
out there. It's like
yeah,
tantalizingly close, I believe.
we are out to transform the way the science is done, and make it just laughable to consider not including women and not understanding women's health.
Yeah, it's way past due, and I think we need to get over ourselves and just, like, force it through because it's enough. So, I'm right behind you, whatever I could do to be helpful, you'll let me know what
Yeah,
song you
absolutely.
have taken. I really appreciate all the time you've been generous to give me to talk to me. I know I've taken a lot of it. Go forth and fight the good fight in Aspen and beyond, Chloe, and we'll circle back after.
All
So
right.
I just want to thank you again for all the work that you're doing. It's super important. You have a
Thank
good day, and
you.
I'll be in touch. Bye
All
now.
right.